Day of Persons with of the International Day of Persons with Disabilities. We are welcoming you to this webinar, From Cost to Investment, Financing Health Equity for Persons with Disabilities. This is co-hosted by the International Disability Alliance and the World Health Organization. Today's webinar has language interpretation. We have language interpretation in Arabic, French, Spanish, as well as Chinese. You will be able to enable language interpretation and French. We will be able to enable language interpretation using the globe icon at the bottom of your screen, and you can choose the language of your choice. There is also captions. My colleague is putting the link to external captions in the chat box, which you can enable. We will also have, of course, international sign interpretation, and please pin the interpreter as you require. With that, it is a very busy webinar. We have many speakers, and I welcome you all. We will not delay any further, and we will jump straight into the welcoming remarks and the opening remarks of the President of the International Disability Alliance, Dr. Nawaf Kabara, who will be speaking to us about the urgency of this topic and why it is such an important topic for something like the 3rd of December. Thank you.
Thank you, Ambar. Good morning, good afternoon, and good evening to all who are joining us from around the world. Happy International Day of Persons with Disabilities. On behalf of the International Disability Alliance, it is my pleasure and honor to welcome you to this important webinar on financing health equity for persons with disabilities. This year's theme for International Day of Persons with Disabilities is fostering disability-inclusive societies for advancing social progress. Today's conversation goes to the heart of what disability-inclusive society truly means. We cannot speak about inclusive society without addressing the persistent and systematic inequities that 1.3 billion persons face in addressing quality, affordable and inclusive health services, and accessible information. We cannot speak about inclusive society when 16% of the global population face the risk of dying 20 years earlier. It is true to have made advancements in terms of a global commitment on inclusive health. Earlier this year, at the Global Disabilities Summit, close to 100 commitments on inclusive health were mobilized from multilateral, bilateral government foundations. To date, the Committee on the Right of Persons with Disabilities has reviewed and issued recommendation on Article 25 to about 114 countries. The World Health Organization recently launched the Disability Health Equity Initiative, a remarkable initiative that will transform how conversation in health sector are informed, designed, and delivered. This initiative, which brings together close to 172 members, hold immense potential of organization of persons with disabilities to meaningfully inform health sector processes. I am happy to inform you that IDA and our member Down Syndrome International will be co-chairing the work stream 1 on building leadership on health equity among persons with disabilities. Colleagues, even as we acknowledge this progress, we admit that we meet at a time when disability inclusion is under immense strain. This year has particularly been challenging for disability inclusion. Disability inclusion is the heart of exchange. The standards that guarantee equality before the law are being targeted and weakened. Health equity for persons with disability means less out-of-pocket expenditure, more money in the pocket of persons with disabilities, and adequate standard of living. It also means persons with disability can equally participate in gainful employment and contribute to our country's economies. As I close, I want to thank our partners, WHO, for the leadership in shaping this important conversation. I also want to thank all the panelists, the World Bank, the FCTO, Ministry of Health, Kenya, IDA members, for joining us on this International Day of Persons with Disabilities. I wish you all a fruitful conversation.
Thank you very much, Nawaf, for your remarks and for setting the stage. We will be dividing this webinar into several parts. And in the first part of this discussion, framed by Dr. Kavara, we will be doing a deep dive into the issue of health equity for persons with disabilities with 3 expert presentations from the World Health Organization as well as from the World Bank. Our first speaker for this session is Karin Stenberg, who is the WHO health economist, and she will be doing a presentation for us on universal health coverage. Karin will be sharing her screen for a presentation. So Karin, the floor is yours.
Thank you very much. And it's an honor to be here today with you. I hope that you can see my slides. It's a great pleasure to be here to have this chance today to contribute to the discussion on how we can expand access to healthcare for persons with disabilities. I will specifically address the agenda of universal health coverage, or UHC, and how UHC can be a driver of inclusive health policies. As we all know, health is a human right, yet millions of people still lack access to essential services. But in recent years, UHC has gained significant momentum as a pathway to equity. And it's now a central pillar of the Sustainable Development Goals for health, where target 3.8 is about universal health coverage. At country level, we have increasingly seen UHC embedded in national health strategies. So what is universal health coverage? It has 2 main principles. The first one is access, to provide all people with the needed health services, different kinds of services of sufficient quality to be effective. And the second principle is protection, to protect people from financial hardship. The use of health services should not lead to financial hardship. So the first takeaway from my presentation is that UHC is about these 2 things: access to services and financing. But today, billions of people cannot access all the essential care they need, and millions of people fall into poverty because of health costs. They lack financial protection. So even if they can access and use the services, they have to spend a lot of money to access them. What data do we have? This map shows how countries are doing. In every country, there are people who have limited access, but in some countries, the needs are greater. All the countries here marked in yellow or red, that means that less than 60% of the population would adequately access health services. So we see in a lot of countries, there are very huge gaps in healthcare access. This is for the general population. Unfortunately, we don't have the breakdown for different population groups with disability status. And the second indicator in financial hardship, here again, we can see wide variation between countries. We measure this as the proportion of the population that is impoverished and further impoverished at the relative poverty line. Countries with medium and dark purple on this map means that more than 10% of the population has suffered from impoverishment. Globally, almost 2 billion people face some form of financial hardship when they seek healthcare because of paying out of their pockets. When we consider people with disability as today in UHC, we must remember that this concerns many aspects. It concerns expanding access to what we can call disability-related health services, such as assisted technology and rehabilitation. But also very importantly, it's about expanding overall health service access to the entire population. It includes everyone, including people living with disability. What can countries do? When we talk about UHC, we talk about three things: reduce cost sharing and fees, expand population coverage, and expand the kind of services. Very importantly, UHC is a direction, not a destination. No country will ever arrive at the perfect place. But every country can move stepwise up the ladder. And the rationale for doing it is very different across countries. In some countries, it's important for national unity. It can be part of a state-building agenda or building public trust in the state. It could be because of an election and getting votes for your party. If you promise them a reform for UHC, or to show economic development, or to motivate economic development. And when we talk about UHC, we usually show a box. And again, there are these three kinds of actions we can do. The first one is to expand the coverage, expand the entitlements as we call it, to the population, including those with disability. We can also expand the services, so the kind of services that people get. And here we have both general services as well as specific impairment-related conditions, which not many governments provide. They often rely on NGOs or donors, and it's important to take this into consideration. And the third dimension is functional. So again, we can reduce patient fees.
Karen, can you project your voice a bit? Because it's getting a little muffled, if that's all right. Thank you.
Yes, thank you so much for highlighting. I will try my best.
Perfect. This is good. Thanks.
Good. So what are the practical steps? So here I'm emphasizing the need for robust health financing policies and using existing resources efficiently and equitably. Firstly, to raise resources for health is very important, and to do this using fair approaches, such as progressive taxation. And here, I think especially for people living with disability, it's very important that we have these fair, progressive ways of raising the resources. So this should be part of the policy discussions. The second question that should be part of the policy discussions are how to pool resources. Often you can have resources sitting in different pockets, like donor funding or different health insurance schemes, and it's important to bring them together to spread the risks. A third very important policy aspect we need to think about is providing healthcare for the entire population. And the instruments we can use are the budgeting and purchasing of services, how we buy them, make sure we reach everyone, including people living with disability. And fourthly, it's about setting priorities. So how can we decide which services to provide? And I just want to highlight here that for the right-hand side of this graph, the available resources, it's very important to think about public funding, because we see that public funded systems perform better on UHC. There is less out-of-pocket payment and there is more equity. So UHC is not just about health insurance, it's really about making sure that there is a government public funding investment in healthcare with an equitable outcome. And then secondly, also, it's very important to say UHC is not just about financing, but it's also about building the health system, building a robust and equitable health system where everyone can access the needed healthcare. And primary healthcare is really the pathway to use to arrive at UHC. So at WHO, part of our work, and especially I work in the financing and economics area, so we recently had a resolution passed in May where we are further mandated as WHO to support countries to strengthen health financing. And we work through a number of mechanisms to do this, but really emphasizing also in line with this webinar today, it's also about positioning health as an investment. And this resolution was sponsored by, you can see here, many of our member states. So my final slide is just to say, we do know today that aid is declining and budgets are shrinking, and we do need to set new priorities. It is unlikely that funding for health will increase in many settings, and we may rather see a reduction in resources. So what can we do? We need to work together to find solutions. WHO is actively working to support countries given the current context. We recently launched a document that has some practical steps that can be taken. Just wanted to highlight a few ones here that are relevant for our discussion today. The first one is that countries should focus on improving equity within existing health financing pools, like a national scheme or the government budget, rather than creating new insurance mechanisms. It's better to work with the existing mechanisms and try to reach everyone. Secondly, when we prioritize services, we can consider vulnerability as a criteria, like specific impairments and health conditions. So this is something that we also support countries to do. And thirdly, we also support countries in their processes to establish participatory and inclusive priority setting processes that include persons with disabilities or representative organizations in the process. So I just want to highlight with one key takeaway. We see UHC progressing in many countries, and we can definitely use these policies and health financing reforms as an opportunity to drive change towards more inclusive systems. Thank you so much.
Thank you. Thank you, Karen. Am I audible? Okay, thanks. Thank you very much, Karen, for your presentation, and it sets a very good information basis for our attendees on the role of universal health care. I'm now going to pass to Daryl Barrett, who is the technical lead on disability for the WHO, who is going to present on a more specific area on health equity for persons with disabilities. I just want to make sure that
Thanks, Amber. Can you hear me?
Yes, Daryl.
Okay, great. Thank you very much. Hi, everyone, and happy International Day of Persons with Disabilities. It's great to be able to present this webinar, and thank you, Karen, for setting the scene for what we're going to talk about now. I want to go into a little bit more detail about really what we're talking about, some of the issues when it comes to persons with disabilities and health financing. So I'm going to start off by reminding us all about really what we already know. We know that people with disability who make up a significant proportion of the population, 1 in 6 of us, experience really poor health outcomes compared to everybody else. People with disability are dying much earlier, and they're at more risk of developing a range of health conditions. And this situation is really something that we can't put up with anymore, particularly on a day like this. We need to be recognizing that it's time that we change the status quo when it comes to the health outcomes for people with disability. Now, it's important also to highlight that these issues, these inequities, whether it's people with disability dying earlier or at more risk of developing a range of health conditions, are primarily due to factors that are both within the health sector and outside of the health sector. And one of those relates to investment and how the health system is financed. And there's a range of different factors, whether it's about the action or the inaction from policymakers, or where it's to do with limitations in persons with disabilities being able to be part of decision making. But what it means is that our health systems today are not really fit for purpose when it comes to persons with disabilities. And that's something that we have to change. And so some of the specific issues around health financing and persons with disabilities can be put down to a few different specific issues. And I might just add that this information can be further found in the WHO Global Report on Health Equity for Persons with Disabilities. But let me just highlight a few points. Karen mentioned the issue of service coverage and how services reach people in the population. We know that people with disability are often not covered by a range of health services, and this can impact them when they need regular medication or other underlying interventions that are needed by the health system. We also know that health services are not really set up to promote accessibility. Often we see budgets in health systems that have 0% allocated to ensure accessibility of various services, whether it's physical or virtual. And we also see then, by extension, that reasonable accommodation or reasonable adjustments that need to be provided to support people to overcome these barriers are often not budgeted for. So there are a few of the issues that we know are experienced by persons with disabilities in the health sector. We also know that discrimination is very present in many health systems, if not all health systems around the world. And this can be seen in a range of ways, including, for example, when it comes to insurance. People with disability are often not able to get the same level of insurance because of an underlying impairment that they may have. We also see that results in people with disability being uninsured or underinsured, which again has significant impacts on the costs that they bear. And what this all means is that essentially systems for financing the health sector are really not inclusive. And what they end up doing is further aggravating the situation and poor health outcomes for persons with disabilities. Now, even though I've painted a somewhat gloomy picture of the current status quo when it comes to persons with disabilities in the health sector, we are taking steps to address that. And as Karen mentioned in her presentation, governments are looking to advance on universal health coverage. And one of the ways they're doing this is by taking various steps in the health system to be able to address some of those issues. And we see, for example, health financing as a major part of the health sector that needs to be addressed. And so WHO, we've developed a toolkit to support governments to address some of these areas, including health financing. And some of those countries that we've been working with include Cote d'Ivoire and Tanzania and Nepal and Cambodia, just to name a few. And so what I wanted to highlight are three areas that we can look at taking control, I guess, of some of the barriers and some of the challenges that people with disability experience. One of those is what's referred to as progressive universalism. And that's just a fancy term for essentially saying that if we want to make a difference for people who are often most left behind, we have to put them in the center of what we are doing. So when it comes to persons with disabilities who we know are often being left behind, we need to make sure that they are included in decision making about how health systems are financed. And this is whether it's in relation to legislation or how investments are put down or how policies are put forward. The second area where we know we can make a difference, and as Karen alluded to this, is looking at services for specific impairments and health conditions in the packages that are developed as part of universal health coverage. And these are very important because we often see that people with disability are not able to access certain services that they need to be able to address some of the underlying health conditions and impairments that they have in relation to disability. I will also say that it's not only about the types of services that are delivered, but it's also about how the services are delivered. And what I mean by that is we recognize that people with disability need every single health service that's being provided, not just a small range of specific services. But for those services, for all health services to be of use, they need to be accessible and inclusive. So it's also about how the packages of care are delivered. And this also relates to work we're doing with a range of countries across the globe. And the third is really looking at how our facilities and services are accessible. Health financing can be a powerful tool in terms of leveling the playing field when it comes to accessing health services. It's still incredible that we are talking about the need to make health services accessible when we know that many people with disability and many people without disability struggle to access health services because they often don't hear so well or don't see so well or don't move so well. So accessible health facilities and services should be just part of the DNA of a quality health system. Now, one of the ways that WHO is taking steps to address those challenges and to move forward on those three recommendations, as Nawaf mentioned, is through our new WHO Disability Health Equity Initiative. And this initiative was launched this year, and essentially at the heart, we want to make sure that people with disability are having the same health outcomes as everybody else. And we will focus on 4 areas. One is around building leadership among persons with disabilities when it comes to health equity. The second is elevating the political prioritization in terms of health equity. And a webinar like this on the 3rd of December moves the needle in that direction. The third area of focus is really about what we need to do to create inclusive health systems. And this is where health financing really comes in. We won't have inclusive health sectors or an inclusive health system if we don't have financing. And the third is to make sure that we're monitoring and ensuring that we've got robust indicators to follow where we're going. The way that the initiative will operate really is to have WHO continue our normative work of developing country guidance and technical work. It's to engage the private sector so that private health sector companies, whether it's medical technology companies or diagnostic companies, are all moving in the direction of health equity. And of course, having a network of stakeholders, again, and as Nawaf indicated, with IDA and Down Syndrome International being part of the network. We launched it on the 12th of November in Geneva. And this new network will help drive the change that we need to see at the country level and support coordination at the country level for this health system change that we're looking at. So look, the last slide I want to leave you with are just the 3 real basic recommendations or steps that we can take to address the gaps in health financing in relation to disability. One of those is making sure that persons with disabilities and issues around disability are at the center of addressing health financing challenges. The second is to look at what specific services need to be included and how those services are being delivered as part of our packages for universal health coverage. And the third is to make sure that our budgets around the health system address the accessibility barriers that currently exist and lock people with disability out. And if you want to know more about any of these topics, there's a QR code on the screen. So if you want to have a look at that, will take you to the pages that that will share more information. So with that, Amber, I'll pass back to you. Thank you.
Thank you, Daryl. Thank you very much. Our next speaker is Charlotte McLean-Nalpo, who is the Global Disability Advisor of the World Bank. She is very familiar to those of us in the disability sector. Welcome, Charlotte. The floor is yours for your intervention on collaboration and partnership with states, which is the next phase, I think, of the questions that Daryl has raised, and how we see acceleration for health equity for persons with disabilities. Thank you.
Thank you, Amber. Thank you very much for inviting me to enjoy this really important gathering in which we commemorate the International Day of Persons with Disabilities. As mentioned by Amber, my name is Charlotte McLean-Nalpo. I'm the Global Disability Advisor at the World Bank. I'm a middle-aged brown woman with long brown hair, and I'm wearing a pink jacket today. So it's really my pleasure to be with all of you today and be part of this very important webinar. Since 1992, this day has been celebrated to promote the rights and the well-being of persons with disabilities in all spheres of society and development, including their right to health. The day is intended to give an opportunity to renew our focus to including persons with disabilities in the work at the World Bank, but beyond. It reminds us that persons with disabilities must benefit from and meaningfully participate in development outcomes. So the World Bank's mission is to end extreme poverty and boost shared prosperity, and it is inseparable from disability inclusion. As mentioned by other speakers, and I think it's worthwhile mentioning, we know that persons with disabilities make up about 1.3 billion of the global population, and that we face disproportionate barriers to seeking and accessing healthcare services and are more likely to experience catastrophic health expenditures. Therefore, improving the health and well-being of persons with disabilities is a direct investment in human capital and very much so in poverty reduction. The UN Convention on the Rights of Persons with Disabilities, which now has almost universal ratification, obligates, and I underscore, obligates the right of persons with disabilities to the highest attainable standard of health without discrimination. State parties are therefore required to ensure equal access to healthcare services, including the full range of healthcare services that persons with disabilities may need. And that may include rehabilitation, access to assistive devices and technologies. Now, the World Bank has the environmental social framework, and we also have a disability inclusion and accountability framework. And within these frameworks, we've embedded the principles of non-discrimination, the principle around accessibility that Daryl spoke about, the importance of participation, and universal access across all of our operations. These institutional frameworks have been pivotal for the way we do work at the bank because they provide an architecture for our projects, but also for countries to operationalize Article 25 of the CRPD. So I'd like to share with you today some ways in which the World Bank, in partnership with country governments, have begun to address and accelerate health equity for persons with disabilities. And maybe I just want to start with a very basic but important starting point. And that is we have to recognize that inclusive policies which address the needs of persons with disabilities are foundational to building inclusive health systems. And to support that, what we have done is to provide the knowledge, the analytics, and the technical assistance that can then be embedded in health policies and benefit packages. A key component to ensuring that benefit packages are responsive to the needs of persons with disabilities is identifying the costs borne by persons with disabilities and their households, including both the direct and indirect health care costs. On this note, I'm really thrilled to share that the World Bank, in partnership with UNICEF, recently launched the methodological guidelines on accessing household disability. These guidelines explore different methods for accessing disability-related costs, and how such findings can be used to identify priorities. We can't talk about financing if we don't know what we're looking for. We need to understand what those issues are. So understanding the size and the composition of these costs, for example, the costs of healthcare services and medicines, as well as indirect costs such as transportation, can provide us with insights to ensuring that programs and policies align with the needs of persons with disabilities. Moving from policies to services, the bank finances the construction of accessible healthcare facilities and invests in building the capacity of healthcare workers to provide quality care that's respectful and that's rights-based. Under the World Bank's environmental and social framework, and in particular with the environmental and social standard number 4, in which we mandate universal access, that then also includes access for persons with disabilities. The environmental social framework and the disability inclusion and accountability framework require accessibility and universal design to be integrated into all World Bank finance infrastructure, including into healthcare facilities and healthcare projects, something that Daryl has already spoken about. To this end, the World Bank partners with governments by financing the construction of accessible hospitals and healthcare facilities, which consider the diverse needs of persons with disabilities. And I'll give you an example of where the World Bank has supported accessibility improvements in healthcare facilities across 30 provinces in Vietnam. And this was done through the integration of universal design features into the design and renovation and or construction of rural commune health stations. So that's just one example. The bank has also developed several resources to support governments with incorporating accessibility and universal design in health care projects and healthcare infrastructure. And to this end, we have developed a building code checklist for universal accessibility. We have a technical note on accessibility. We have guidance on resilient and green inclusive healthcare facilities. And that's just to mention a few of the technical pieces that we've developed. It's essential for us to continue to develop the knowledge that can then be translated into operational work. So beyond the accessibility of healthcare facilities, we're partnering with governments to remove barriers in accessing healthcare services, from the prevention of non-communicable diseases to the provision of rehabilitation. A crucial step in this process is engaging persons with disabilities and their representative organizations to ensure that project designs are informed by the lived experience of persons with disabilities and that their needs are centered as mentioned by Daryl. And a good example of this is a project in the World Bank project in Ghana, where we've been engaging directly with organizations of persons with disabilities and working to ensure that the information, the health information that we glean from these discussions then is translated into the operational design of the bank's project. And so in this particular project, we're looking at providing accessible formats such as Braille and sign language, and really ensuring that the voice and the agency of persons with disabilities is represented and reflected in the design of the project. As I close, we know that there is so much more to be done in order for us to realize the promise of Article 25 of the CRPD. The bank stands ready to support state parties to translate the CRPD commitments into tangible development outcomes, and in so doing, making disability inclusive health an integral part of health systems and ensure equal access to healthcare for all persons with disabilities. Thank you.
Thank you, Charlotte. And we are going to pass to Gayatri, who's going to take us through, with all of this context, she's going to take us through a participatory exercise to know what all of your experience has been. Over to you, Gayatri.
Thank you, Amba.
So this has been a lot of information that we've been receiving, and it's time for us as participants to share our experiences. We will now run a poll on this webinar, which will be launched now. This poll has 3 questions. I will read each question out so that it reaches the interpretation. The first question: what are the biggest health financing challenges limiting access to healthcare for people with disabilities in your country? For example, out-of-pocket costs, lack of costing and budgeting for government programs, high transportation or accessibility costs. This question requires you to type in your answer or dictate your answer in. The second question is a multiple choice question. There are 4 choices. The question is, are people with disabilities covered under the universally available health benefit packages that are funded from public revenues and/or nationally funded health insurance? Again, the question is, are persons with disabilities covered under the universally available health benefit packages that are funded by public revenue and/or nationally funded health insurance? The options are yes, fully covered. Second option, partially covered. Third option, not covered at all. Fourth option, I'm not sure. The third question is also one in which you will have to type or dictate your answer to. The question is, if you answered yes or partially to the second question, what key benefits are included for persons with disabilities and what is excluded? The third question again is, if you answered yes, option 1, or partially, option 2, to question 2, what key benefits are included for persons with disabilities and what is excluded? This poll will be open for 1 more minute. This poll will now be closed.
Thank you very much, Gayatri. And we're going to give you some time to crunch the numbers that we receive on the poll and to present the results in a bit. So please stay tuned for that after the next section of our webinar, which is talking a little bit about what has been the experience of persons with disabilities when it comes to financing health equity. And for this, we have 4 speakers in this panel, and we will be starting off with the perspectives of 2 organizations of persons with disabilities, both representing underrepresented groups of persons with disabilities. We are going to start with Carla Cosin, who is the president of the Bolivian Federation of the Deaf. Carla, can you tell us about the affordability or the experience of affordability of health services for deaf women in Bolivia? Thank you.
Muy buenos días a todos. Bueno, buenas tardes en algunos otros países. Estoy muy agradecida por la oportunidad que me brindan para poder dar esta exposición. Creo que es muy importante hablar de estos temas y también urgentes. Son temas de derechos humanos y estamos hablando de la realidad en el servicio de salud para mujeres sordas. En Bolivia se puede hablar de este tema ya que existen muchas
sorry, can I just ask the interpreter to pause?
iniciativas.
Sorry, I just want to know if is the English channel audible? Can someone confirm?
The English channel is audible.
Yes.
It is. Okay. Thank you. Please continue.
Bien, nuevamente buenas tardes, buenos días en algunos otros países. Estoy muy agradecida por la oportunidad que me brindan de participar en este evento internacional, donde podemos hablar de manera urgente y profunda sobre los derechos humanos y la accesibilidad en la realidad en el sistema de salud que vivimos las mujeres sordas en Bolivia. Hablar de este tema no solamente es hablar de unas barreras tanto tecnológicas, administrativas, sino estamos hablando de un derecho humano sobre la dignidad de muchas mujeres sordas. Hoy en día estamos enfrentando muchas barreras, muchos sufrimientos y muchos aplazamientos a nuestros derechos. En Bolivia tenemos muchos derechos que se han reconocido, pero no se ponen en práctica. Tenemos la ley 1658 y la constitución misma, la misma constitución política del Estado, que ampara y es el sostén legal, pero muchas personas sordas no acceden a estos derechos, al contrario, están con esas barreras, especialmente en accesibilidad. El costo para las mujeres sordas para acceder a una salud es mucho más alto que para cualquier otra persona. La atención, en primer lugar, enfrenta muchas
I'm very
barreras.
sorry. I'm very sorry. I have to ask you to stop. There is some technical issue and the English channel is not audible. Carla, please accept my apologies. We will just work out this technical issue.
Hay algún problema técnico y el canal de la mancha no es audible. Carla, por favor acepta mis disculpas. Simplemente resolveremos.
Perdón, está bien. Vamos a ir un poco más lento.
That is okay. I will wait.
Okay. Thank you, Thelma, for your. I will now invite, while we resolve the technical issue, I'm going to invite Nathan Rowe, who is the program manager for Down Syndrome International, who will speak about the affordability of health services for another underrepresented group of persons with disabilities and their families, which are persons with intellectual disabilities. As was mentioned, Down Syndrome International is a very strong partner on health equity for persons with intellectual disabilities in this partnership and in general. So Nathan, the floor is yours.
Thank you, Amber. Happy International Day of Persons with Disabilities, everyone, firstly. As Amber said, my name is Nathan Rowe, and I'm here representing Down Syndrome International. We are the global network of persons with Down syndrome and their families. I'm also speaking to you as a brother of a woman with an intellectual disability. My sister passed away in 2021, but I remember very well the barriers she faced trying to access healthcare. Today, I want to share some key concerns regarding the affordability of healthcare, specifically drawing from our global report, Our Say in Our Health. It was published in July this year in partnership with Humanity and Inclusion. This report is really unique because it is based directly on the experiences of people with intellectual disabilities, families, and organizations around the world. For persons with disabilities worldwide, the affordability of healthcare remains a fundamental and critical barrier. In our reports, we heard that healthcare is affordable for less than half of people with intellectual disabilities. So really a low number. And when we looked specifically at low and lower middle income countries, that number fell to below 20% of people who found it affordable. While there is progress happening towards universal health coverage globally, our report showed that public healthcare systems and national health insurance schemes frequently exclude people with disabilities, including in countries with well-established public systems. And even when they are theoretically included, the services they receive are often unavailable, inaccessible, or of such poor quality that they are unusable. We heard this clearly from a respondent to our consultation from Namibia, who told us the state services are of poor quality and are very limited. There is only one speech therapist for the whole country, and private services are very expensive. And we saw a similar pattern even in higher income countries. A respondent from Ireland told us, we can access all services as a medical card holder, but waiting lists can take years. Having private medical insurance is essential to access care in a timely fashion, but it is very expensive. The reality is that state services are often scarce and deficient. As a respondent from Panama told us, you must pay for everything, and unless you have unlimited resources, there's no way to provide all supports needed. And we actually heard stories of people having to choose which essential health service to pay for because they could only afford one. And that is a choice that nobody should have to make. It's not just the immediate costs of healthcare. People with disabilities face additional hidden barriers to accessing healthcare, such as inaccessible public transportation. If you cannot get on the bus, you're reliant on private taxis or personal transport, which costs significantly more. And while some governments subsidize going to the doctor, they often do not subsidize getting to the doctor. A respondent from Canada put it very plainly, social services reimburse travel expenses, but it is a joke if the transport involves a car. The reimbursement is so minimal, it borders on ridiculous. The result of all this is that those who can pay resort to private options, which can have devastating financial effects on them and their families. And for those who can't pay, they often don't really have many options at all. So they either accept poor quality healthcare that doesn't meet their needs, or they get no healthcare at all. And I want to talk about the impact of this. So when healthcare is unaffordable, the consequences can be tragic. We heard in our report from one family in Ethiopia who described how they would have had to pay 15,000 US dollars to travel to India for a heart operation for their daughter, as they couldn't access it in their country. And this was simply impossible for them. So a horrible, horrible consequence of unaffordable and inaccessible health services. The cost isn't just financial. When quality care is unaffordable, people are forced into unsafe situations. We heard from a woman in the United States who said, when I went to get a blood test, I said that I was scared to do it. The lady called in 3 other people to hold me down. And ultimately, this lack of affordability leads to the worst possible outcomes. So one that stuck with me from the WHO global report is that children with intellectual disabilities in the UK were 8 times more likely to die before the age of 17. And that is in a country with free public healthcare. So looking forward, what needs to be done? In this webinar today, we're hearing a lot of innovative solutions to improving health financing. But to make these financing models really affordable for people with disabilities, we cannot just look at numbers. We need to hear from the experts. And by the experts, I mean people with disabilities themselves and their representative organizations. Organizations of persons with disabilities must be at the table when you're designing financing models and packages to ensure that they actually cover the real costs people face. And that includes those that are often aren't included, such as organizations representing people with Down syndrome and intellectual disabilities. So thank you very much for listening to me. I'm looking forward to listening to all the other great speakers, and that's it for me. Thank you.
Thank you very much, Nathan, and for sharing some of the insights that you received in your global report on healthcare for persons with intellectual disabilities. And so the examples which were shared definitely highlight the urgent need for all of the reforms that we have been talking about to be implemented. Unfortunately, we still have not resolved the technical issue with regard to Carla's presentation. So I am going to move to Carolyn while we do that. Carolyn Wood is the team leader, Sexual Reproductive Health and Rights and Demography in Africa. And Carolyn, and this is regarding the WISH project, which she will be telling us about. Martha, financing health, we know, can facilitate or hinder availability, accessibility, and even uptake of sexual and reproductive health services, which is such a sensitive issue, especially for women with disabilities. Can you tell us about how the WISH program facilitated access to sexual and reproductive health services by women and girls with disabilities? Thank you.
Just because my bandwidth
is
not great, and I don't want to risk.
Do we not have?
Can you hear me?
Okay, I think that it's not a problem. Carolyn is not on the call right now.
She's here. I can.
Oh, she
I'm here.
is? Okay, there she is. There we see.
Can you hear me?
Yes, Caroline.
You can hear me?
Caroline, I cannot hear you.
Sorry, I can hear you, Caroline.
Okay. Some people seem not to be able to hear me.
Miriam, you can hear?
Yes, I
Might
can
be-
hear.
It might be my connection. Sorry. Thank you.
Shall I continue?
Yes, please.
Okay, thank you. And I won't turn my video on just because I'm concerned a little bit about the bandwidth, but I'm really glad you can hear me. So first of all, happy International Day of Persons with Disabilities. And thank you for inviting me to speak here at this webinar. I'm delighted to share insights from our program, Women's Integrated Sexual Health Program, otherwise known as WISH. WISH is the UK government's flagship sexual reproductive health and rights program in sub-Saharan Africa. And we focus on strengthening systems and supporting last mile delivery, prioritizing adolescents, people with disabilities, and especially those living in fragile and conflict-affected states, where maternal mortality and adolescent fertility remain high. Since this program was designed, WISH has been supporting countries to integrate sexual reproductive health and rights into universal health coverage. But WISH fundamentally is about equity and dignity and making services accessible to all. So during the first phase of this program, which ran from 2018 to 2024, with a specific focus on people living with disabilities, we doubled our reach of clients from 2.5 to 5%. I want to share 5 ways in which WISH has facilitated access for women and girls with disabilities through the program. The first thing I want to talk about is ensuring inclusion is a fundamental part of the program from the start and not retrofitted later. True disability inclusive SRHR programming demands systemic change, structural reform, and sustained partnerships. Key to achieving this is ensuring dedicated disability inclusion expertise within consortia from the very beginning. For example, site savers are a fundamental part of our program consortia, enabling strong technical assistance and tools for governments and national partners. Support ranges from helping ministries adapt WHO guidelines on health equity to advising on service delivery models, ensuring physical accessibility, and integrating disability into protocols for informed consent and safeguarding. Embedding this expertise builds long-term capacity on disability inclusion amongst our partners, and examples of support include advice on integrating the inclusion into the delivery, partner tools, materials, and approaches. And many WISH partners have significant reach across Africa. And because this is a 5-year program and the second of 2 5-year programs, this technical expertise has the potential to transform how disability inclusion is integrated far beyond the lifetime of our program. The second thing I want to talk about is the absolute fundamental importance of investing in local capacity and working in close partnership with organisations working with people with disabilities.
Carolyn, can I ask you to just slow down a bit, please? Thanks.
Of course, sorry.
Thank you.
Alongside our government engagement, we work with service providers in inclusive SRHR, disability rights, inclusive communication, consent and protection. Our OPDs are supported to conduct accessibility audits of our structures, such as health clinics, providing evidence for advocacy. Many of these trainings cascade nationally, creating networks of facilitators who champion inclusion in clinics and communities. Our strong partnership with OPDs remains central. They are not beneficiaries, they are co-creators, technical partners, shaping service design, outreach strategies, and accountability mechanisms. Their lived experience strengthens our program, improves relevance, and builds the capacity of WISH partners to make inclusion real and sustainable. The third thing I want to talk about is tackling stigma and bias head-on. WISH addresses stigma and bias through inclusive social behaviour change approaches. They are co-designed with OPDs, and under this programme, this includes integrating disability training into SBC campaigns and strategies, workshops at country level to define what accessible and inclusive SBC looks like, and training youth ambassadors, including young people with disabilities, on SRHR and gender-based violence. These efforts, complemented by values clarification and attitude transformation training for healthcare providers, help uncover biases that exist within the services delivered and help to deliver respectful, rights-based care. And together, these interventions challenge the harmful norms that make SRHR services more inclusive and equitable. The fourth thing I want to talk about is policy and financing. Fundamental to our programme is that we support ministries of health to embed international standards and integrate disability inclusion into their national plans, strategies and budgets. And our support to OPDs complements this, strengthening their ability to advocate for the changes they wish to see and set up the accountability mechanisms they need to see these through. Examples of success with our programme is where OPD partners have pushed for inclusion in health strategies, budgets and insurance schemes. For example, in Niger, this led to the National Family Planning Plan, including sexual and reproductive health and rights needs of people with disabilities for the very first time. Under WISH 2, close partnerships with ministries of health have strengthened institutional capacity and embedded international standards. The last thing I want to talk about is that we have to make inclusion not about numbers, but about impact. When we're talking about funding, I was asked to talk about how funding can hinder inclusion. This can certainly be the case, because we tend to pursue results in terms of numbers rather than in terms of inclusion. For example, WISH has been designed explicitly to target those hardest to reach. And in design, we forfeited higher numbers in order to reach harder to reach groups. This is very difficult to do. Numbers are a crude and quick way to demonstrate impact and value for money. And when programs are compared, higher numbers tend to represent better value for money. It takes a lot of advocacy and time to get broad buy-in to the idea we'll reach fewer people, but people who are otherwise consistently excluded. So my final comment is just we need to really think about not being lazy about this. We need to tell a more complex story when demonstrating our impact. So that's everything from me. I feel I've said things that most of you probably already know on this call, but it was nice to reflect on the key things that I think have helped us deliver the WISH programme and made it a standout programme for impact for people with disabilities. Thank you very much.
Thank you very much, Carolyn. And I think that it was very powerful to bring that example of programming because this is something that is a reality for all of us. We're looking now at OPD leadership in inclusive programming, and these are definitely questions and considerations that OPDs need to grapple with. We will take a 20-second pause. 20-second pause on interpretation. So please stand by for 20 seconds while we reset the interpretation to address the technical issues. Can I request that the current IS interpreter is pinned?
When you're done, please give me the host rights back so I can pin the IS interpreter. Thank you.
I can do that. I can do that. Can we check if the channels are working? Can I ask Carla's interpreter to come online to check the interpretation? Can I ask you to just speak to test?
Hola.
Can you speak some
Hola,
more things,
buenos días.
please?
Hola, buenos días. Mi nombre es María Gutiérrez. Soy intérprete de lengua de señas en Bolivia.
Sign language in Bolivia.
Can you speak again, please? Sorry.
Buenos
No,
días.
Okay, wait.
Buenos días. Hola.
Good morning, hello.
Buenas tardes. Probando. Carla.
Can I? Okay.
Trying Carla.
Okay.
Or K.
Gracias. ¿Podemos empezar? ¿Estamos listos?
Thank you. We can start, we are ready.
Perfecto. Bien. Ya después de haber
Perfect.
solucionado este problema técnico, vemos que también es una barrera para todos nosotros esto y bueno, para
Well,
empezar,
after we have solved this technical problem, we see that this is also a barrier for all of us, and well. To begin with, I don't want to waste too much time. I want to thank and greet everyone for this opportunity that is given to us at the Bolivian level. For us, a very urgent issue in the issue of accessibility to talk about the reality of the human rights of deaf women in Bolivia. We are not only talking about an issue of technical or administrative barriers. We are talking about human rights, about the dignity of women and many deaf women who suffer today. Every day there are these barriers and these sufferings that annul the possibility of accessing recognition despite already being recognized by. The Constitution is to have Law 1658. Now that it recognizes the language of the language, it is sign language as a language. For us, it is also very important to be able to access these rights, because we are talking about sustainability in health. Rights that they are especially for us, that add up to a cost.
por la falta de intérpretes de lengua
We
de
can be
señas.
treated correctly, but we
en los
comply with
diferentes
these
centros de
barriers
salud. Acá
because of the
tenemos,
lack of
encontramos
sign
tres
language
niveles de salud.
interpreters.
El sistema de salud
In the different
inicial
health
no
centers
se
here we
cuenta
have
con
and have 3
intérpretes.
levels of health
El segundo y
system.
tercer nivel tampoco
Initial
cuentan
does
con
not have
intérpretes.
interpreters.
Eso no garantiza el acceso a la salud. Las mujeres sordas tienen
The
que
second and third
buscar,
levels
ya sea
also do not have
familiares
interpreters.
o ya sea
That guarantees us
intérpretes que
access
tienen
to
que
health.
pagar para poder acceder a la salud.
Deaf women have to look for either
O
relatives or
acceder
interpreters
a
who have to pay
apoyo de la
to be able to
familia, ¿no?
access health.
Pero esto afecta su autonomía y su privacidad. No tienen esa independencia y
Or
autonomía
access to
para
family
poder
support,
hacer
no, but
o
this affects
recibir
their autonomy and privacy.
una atención médica
Don't they have that
especializada. A
independence
eso
and
se suma el
autonomy to be able
costo
to make or
que
receive
tienen
one?
que pagar en algunos momentos
Medical
para
care
hacerlo
with
y
accessibility,
acceder al
to that is
servicio de
added the
salud.
cost.
Muchas mujeres sordas evitan por
What do
eso
they
ir
have
a
to
un
pay at
sistema de
sometimes to
salud.
do and access the health
No
service?
existe
That is
capacitación en
why
lengua
they
de
avoid going
señas
to a health system.
real, ¿no? Que pueda buscar
There is no training in real sign
una
language.
atención
Not that
adecuada.
I can
Muchas
search.
mujeres que viven en lugares alejados, provincias, tienen que viajar horas de horas para llegar a un centro de
Adequate
salud,
care. Many women who
para
live in
ser
remote
incluidas,
places,
para ser
provinces,
incluidas
have to
incluso
travel
laboralmente.
hours and hours to get to a health
Es una
center.
decisión que ellos
To be
toman
included
y
or
no
to be
viven
included
médicos,
even in the workplace.
suspenden su atención, no se previenen las
It is a
enfermedades, no
decision that
hacen
they make not to
seguimiento de
go
los
to the doctor.
tratamientos
They
y
suspend
lo
their
más
care.
importante, no reciben la información
It
adecuada
is
y
not prevented.
adaptada a lengua de señas.
Diseases do not
Cuando
follow up
ya
on their treatments, and most
cuando una
importantly,
enfermedad
they do not
cambia
receive
de
adequate
órgano,
information adapted to sign
embarazada,
language.
no reciben esta información sobre los derechos
When they
sexuales,
are with any
no
disease,
reciben información sobre
whether
sus
it is
derechos
cancer
en
or they
el
are
sistema de
pregnant,
salud. Las mujeres sordas
they do not
tienen que
receive this
depender de
information
otras
about sexual
personas para
rights.
recibir una
They do not
adecuada
receive information about
orientación.
violence in the health system.
Ellas mismas
Deaf
saben
women
que
have to
les
depend on
cuesta y
other
se
people to
esfuerzan
receive a minimum
por
of
llegar a
information.
recibir esta información, por tener algo de acceso o tener intérpretes que puedan
They themselves know that it is difficult for them and they strive to receive this information, to have some access, or have interpreters who can.
Esto para nosotros es importante que se alcance a
That is important to
tener
us.
esta atención
That
de
it is
salud
reached
y
a.
no sufrir de estas barreras institucionales y públicas que no brindan la atención adecuada o cuando ellas quieren realizar una denuncia se privan de hacerlo.
Those of
No
these
pueden
institutional and
firmar
public
esta
barriers that do not
evidencia
provide
porque
adequate
no
attention
conocen
or
la
when they
lengua
want
de
to make a
señas
complaint.
y tampoco tienen los recursos
They deprive
económicos
themselves of doing
por lo que
so.
son
They
privadas
can't
en su
because there is no
acceso
medical
y en
attention.
defensa a la justicia y a la
Psychologists who know
salud.
sign language
No
and they do
existe
not have the economic
capacidad
resources,
que tienen
so
las
they are
mujeres
deprived in
sordas
their
hoy en
access,
día
in
de
their
la
defense of
comunidad sorda
justice,
como
of
mujeres
health,
sordas.
and many more
Entonces,
topics.
los líderes estamos yendo formando, estamos buscando formas de
What do they have to face
reaccionar y
from the deaf
manejar
community as
esta
deaf women in
información
Bolivia?
desde nosotros mismos, ¿no? Queremos mostrar
Leaders are
que se
being
puede
trained.
llegar a una
Are we
salud.
looking for ways to
Hay
adapt material? But
grupos
we
de
do it from
personas
ourselves, right?
sordas que es importante que les llegue la información para que ellas tengan salud,
We want to show that
tratamiento
access can be reached to this
y
group of
no
deaf
dependan
people. It
siempre
is
de
important to get them the information so that they have health, treatments, and do not always depend on the will.
que se hacen a mediano plazo para
From
poder
small, short projects that are
solventar
made
estas
to
actividades. Ahora que ya
medium term to
se
be
ha
able
declarado
to solve
como
these
idioma
activities.
oficial la lengua de señas y ya vamos a tener,
Now that
esperemos,
sign
un
language has
mejor
been declared an
servicio
official
de
language in Bolivia.
interpretación,
And we are going to
personas
have, let's hope for a
capacitadas
better service,
en estas áreas del
interpretation.
sistema de salud.
Interpretation more trained in these areas of the health system.
Ah,
Sorry.
ingresos de llamadas no me han permitido poder terminar. Para
Call
nosotros,
revenues have not allowed me to be able to. Finishing is important for us.
era la salud. Las madres de familia
To be able to health.
sufren violencia, las mujeres sordas sufren violencia, no pueden hacer las denuncias, no hay métodos, protocolos que nos ayuden a llegar
Do
a
mothers
este
suffer
tipo de
violence?
casos. Por lo
Deaf
que
women
nosotros
suffer violence. Can't
necesitamos
they file complaints?
algún
I
tipo
don't
de
know. There are no
programa,
methods, protocols,
financiación para
that they
llevar a
help
las
us reach this
personas
health service for
aquí
what we
en el
need.
sistema de salud, para que ellos puedan aprender la
Of
comunicación
some kind of
básica
program,
en lengua
financing
de
to reach
señas,
people,
ya que no
doctors, the
contamos
health
con los
system,
suficientes intérpretes. Para nosotros es importante acceder a la
so
salud
that they
en
can learn
Bolivia,
basic
que las
communication in
mujeres
sign
sordas
language,
puedan acceder
since we
a
do
su
not have
derecho a la
enough
salud,
interpreters.
a su dignidad, a su privacidad y a tener una justa atención y lograr que en
It is
este
important
país
for us to have access
se
to healthcare in
pueda
Bolivia and that
tener
deaf women can access their
gracias.
right to health, their dignity, their privacy, and to have fair attention and ensure that in this country, you can have access. Thank you.
Thank you very much, Carla, and for pointing out that there are various barriers to participation experienced by persons with disabilities, particularly deaf persons. I thank you for your patience as we resolve the technical issue. We now move to our last speaker of today's panel. And after our last speaker, please, we will have the results of the poll, which you all participated in. It is my pleasure to invite Martha Masi, who is the head of Disability Mainstreaming Unit of the head of physiotherapy services as well of the Ministry of Health in Kenya. Martha, we're going back to the first presentation that we had on universal health coverage. And we'd really like to know a practical experience that you're going to share about the transitioning from the National Health Insurance Fund to the Social Health Authority and how inclusion of disabilities, persons with disabilities, was achieved. Over to you.
Thank you very much. My voice is a bit hoarse because I had a flu, but I'm better now. Thank you for welcoming me here, and I'm glad to be here. So I want to greet us good morning, good afternoon, wherever you are. Here in Kenya, it's afternoon. Good evening, actually. It's 17 hours. And colleagues and partners, I'm honored to speak about the journey of Kenya towards universal health coverage. So much of the things have been spoken about, but Kenya, we want to say that Kenya, we are a bit ahead because we have a law in the land that is governing universal health coverage, besides all other rights in health for persons with disability. And so in the context of this conversation, how UHC and the Social Health Authority, which is now the health packages that are used to cater for services in health. We, of course, recently had the health insurance, national health insurance, which was translated and transformed to the Social Health Authority, which is anchored in the Social Health Insurance Act of 2023. And this reform created 3 funds. And the first fund was Primary Healthcare Fund, and which is fully funded by the government to guarantee prevention and promotive services. And the second one was the Social Health Insurance Fund, which is in short SHIF, for outpatient and inpatient services. And then the third one is the ECCIF, which means Emergency Chronic and Critical Illness Fund, which is to shield the Kenyans from high cost healthcare as access. And so the version is simple but ambitious. So no Kenyan should face financial ruin when seeking for healthcare services, including persons with disability, which are the one among the population. So they often face high costs because of their specific needs. And so in their social economic background, they are vulnerable. And so that is why the government has considered, even after putting the act in place, to ensure that they get their rights when it comes to health. I hope you're getting me. So in this system, we call it a better agenda, that is a bottom up, economic transformation agenda. And so then ensuring this financial protection for persons with disability. So the government funded coverage for vulnerable population is fully funded by the government, whereby there's a central feature of SHA, that is for preventive promotive services, because we're in the UHC dispensation, which is the commitment that Kenya wants a government to fully pay shift contributions for vulnerable households, including persons with disabilities, as per the cash transfer for persons with disability program. Households validated in the National Social Registry as vulnerable. We have also indigents for persons in community mapping exercises, whereby those identified are effectively taken care of. So the effectiveness of this is that persons with disability who are unable to pay will receive premium-free coverage. So in this system, of course, we have removed the one contributor per household, and so everyone contributes one with the other. Unlike NHIF, which there was a contribution on individual basis and would cover for the whole household. And so in this case, families often relied on a single contributor, but SHA introduced a per household enrollment model, reducing the cost pressure on individual persons with disability who cannot sustain monthly contributions. And so this package expanded, and it is also catering for packages. These packages are also taking care of disability-related needs, where SHA guarantees assistive technologies and rehabilitative services for persons with disability, because it's about access for quality health for all. Kenya, we were privileged to start the 80 scale project. We were the pioneer country after having developed a disability assessment and categorization guideline, besides the rehabilitative and assistive technology strategic plan, which now actually gave us the opportunity to have the fund and the project in Kenya. And so in this case, we have assistive devices and products, of course, knowing that assistive technology is about systems, products, and services, where systems have been revamped and then actually enhanced so that they can meet and be responsive to the needs of persons with disability. And so we also have prevention and management of chronic and critical illnesses. We also have community-based health services delivered through CHPs, because CHPs are frontline workers, and actually they are our foot soldiers who identify and then enhance referral systems to refer to the other levels where there's special specific healthcare service for persons with disability. So for many persons with disability, these are essential services that were previously unaffordable and unavailable, and there was a lot of inconsistently reimbursement of amounts that persons with disability would go deeper, and yet they were not easily available. So on emergency and chronic and critical illness fund, a large portion of disabilities are linked to chronic conditions, as we know. And so the ECCIF now protects such households from catastrophic spending on emergency surgeries, long-term treatment for cancer, diabetes, cardiovascular diseases, and all other long-term. We also have a package for dialysis or organ-related care. This is a major step toward ending medical impoverishment amongst households with disabilities. And so integrating the social protection as in the registry that offers cash transfers to vulnerable population like persons with disability. The National Social Registry identifies indigents and vulnerable persons with disability households for government-funded premiums. And so the cash transfer also for persons with disabilities improves the income security and helps ensure that persons with disability can also access healthcare services, improving their well-being. And this helps to ensure that all can afford, even in terms of transport to the healthcare service facilities and other indirect medical costs through minimally,
Thank you.
because this is a new package. So we are also digitalizing and also to promote accessible enrollment so that everyone is covered. We are also having
Thank you, Martha. I'm very sorry, but I have to ask you because we're quite at the end of the webinar. But thank you so much for guiding us for a very concrete example in a country, which is many participants are actually here on the webinar from Kenya. I'm sure they're delighted to hear about the success in this, and it's a great example for everyone else to take home with them as a good practice. I'm sure that you all have been eager about, thank you. You all have been very eager about what happened to the poll that we took part in. So I'm going to pass to Gayatri. Gayatri is going to present us in a nutshell what were the responses. Thank you so much, Gayatri.
Thank you, Amba. The first question that we asked on the poll was what are the biggest health financing challenges that limit access to healthcare for persons with disabilities? Some of the responses we got: out-of-pocket costs being high. This includes medication, assistive devices, travel, parking, and consultation fees. High transportation and accessibility related costs. Lack of budgeting or costing for disability inclusive health programs. Limited availability of specialized services and long wait lists. Inequity between public and private health systems. Lack of financing for assistive technology. Limited awareness of how to access disability-related health schemes. High cost of living and unemployment, reducing the ability to pay. And the last one being poor political will and weak representation of persons with disabilities. The next question was, are persons with disabilities covered under the universally available health benefit packages that are available? 50% of you said that persons with disabilities are partially covered. 21% of you said they are not covered at all. 14% of you said, yes, we are fully covered, and 14% of respondents were not sure. Our last question was, if you answered yes or that persons with disabilities are included partially, what key benefits are included for persons with disabilities? Some of the responses to what's typically included from you were basic or short-term rehabilitation is included, but it's often capped. Limited assistive technology, some mobility or hearing devices are included. Interpretation or communication support, but it is inconsistently provided. Subsidized general healthcare services, special transport, and small financial relief measures. However, these were things that are commonly excluded. Long-term rehabilitation, complex approval processes for assistive technology, leading to exclusion of assistive technology, early intervention, developmental assessments, psychosocial support, often excluded, mandatory co-payments, income-based subsidies not aligned to cost of living, leading to exclusion, and administrative barriers with complex procedures. Thank you.
Thank you, Gayatri. I would have loved to hear your analysis on that. Unfortunately, we don't really have the time. But just to say that this reflects very well with what our speakers have spoken about. And when it comes to financing for health, there is a large amount of work that needs to be done looking at the entire health system and not just individual services. We now have two concluding remarks. One is recorded from Dr. Tedros, who is the Director General of the World Health Organization. I am sharing his video now with you. If you just give me just a moment.
The right to health means the right for everyone to access the quality of health services they need. But around the world, persons with disabilities often have difficulty accessing those services. WHO calls on all countries to build health systems that are accessible, affordable, respectful, and inclusive. That includes the way health services are financed, as part of every country's journey towards universal health coverage. Through our Disability Health Equity Network, WHO is working with partners around the world to make health financing more inclusive and equitable. Because health for all means all, including persons with disabilities today and every day.
Huge appreciation for Dr. Tedros. I will now pass to our last speaker for today, who is Dr. Sarah Collinson, who's the Senior Policy Advisor of Sightsavers and is the co-chair of Workstream 3 of the WHO Disability Health Equity Initiative that we've heard so much about. Sarah, the floor is yours.
Thank you, Amber, and friends and colleagues. To conclude today's webinar and this celebration of the International Day of Persons with Disabilities, I want to close proceedings with a positive message focused on future collaboration and opportunity. We know that investing in disability inclusion in health is the smart thing to do, representing an important investment in health for all, with potential financial returns for every dollar invested. What we urgently need now is unified and joint action to stimulate the investments and the reforms needed to build inclusive and equitable health systems. WHO's new Disability Health Equity Network, already connecting over 150 members from across governments, civil society, academia, and international organizations, provides a powerful new mechanism to coordinate global efforts in this regard. Within this network, Workstream 3 is dedicated to creating a disability inclusive health sector. It focuses on systemic reform and integration of disability inclusion as a core principle in the health sector, not as an optional add-on or a niche concern. Inclusive health financing is central to this work because financing underpins everything else that's needed for an inclusive health system. This work stream offers a new and important platform to catalyze conversations among key stakeholders and to enable us to work together to influence health investments and leverage partnerships and financing to accelerate progress towards health equity for persons with disabilities at the national level. We will seek to demonstrate that putting disability inclusion at the heart of health financing is a smart investment in equity, efficiency, effectiveness, and resilience. And where countries are undergoing major health reforms or large-scale investments, we will work to ensure that disability inclusion is embedded from the start. And we will engage development partners, philanthropy, and the private sector to mobilize resources for inclusive health systems. So to conclude, I invite you to spread the word about the Disability Health Equity Network, the WHO Disability Health Equity Network, as a key platform to ensure that health systems serve everyone, including persons with disabilities. Thank you.
Thank you very much, Sarah, for your concluding remarks and for bringing us more information about the work stream. For those of you who had questions, I hope that you have been following the Q&A box where some questions were responded to. Of course, we will be contacting you all. We will be publishing this recording as well as following up with the with the presentations where feasible. A huge thanks to our international sign interpreters, our CART provider, as well as the company Interprify, which has provided the AI language interpretation for today's webinar, as well as the team at the GDS and the IDA Secretariat that have supported this webinar, including Miriam, Arsha, and Gayatri, and the team at WHO for their work on this as well, particularly Daryl and Francesca. Thank you very much. We will also have more global webinars in 2026 on different thematic areas, so please follow please follow the social media of the International Disability Alliance for updates on that. I would request all panelists to put on your cameras for a group photograph. Thank you very much for staying till the end. And for the rest of you all, I wish you a very happy International Day of Persons with Disabilities and week ahead. Thank you very much.
Thank you, everybody. This is Gayatri. I will just be guiding us through our photograph. If I could just request all panelists to please turn on their cameras.